Okay, we're going to cover chapter 20, which is postpartum physiologic changes. This chapter is actually pretty basic, and I think there were only 9 pages in the book, so we're going to go through it pretty quick. The important thing about this chapter is you have to know the normal to understand the abnormals and the potential complications during the postpartum period. Here are your learning objectives. And the other thing is, too, I am unable to upload my notes here in Florida, but as soon as I get back to Kentucky, I'll upload my class notes just like I have for the past several chapters. So postpartum, also you'll see it abbreviated PP like that very often in the clinical setting, is the period, is the interval between birth and the return of the reproductive organs to their non-pregnant state. It's also known as the puerperium, or 4th stage of pregnancy. It lasts approximately 6 weeks. The second bullet lists the different changes that goes on in the uterus. The involution process is defined as the return of the uterus to the non-pregnant state. It begins immediately after expulsion of the placenta. At the end of the 3rd stage of labor, the uterus is located midline and 2 centimeters below the umbilicus. In the clinical setting, you also hear that referred to as 2 centimeters or 2 finger breadths below the umbilicus, because each finger is about 1 centimeter wide. Within 12 hours, the fundus can rise to approximately 1 centimeter or finger breadth above the umbilicus. By 24 hours, the uterus is the same size as it was at 20 weeks. It descends approximately 1 to 2 centimeters every 24 hours. And by the 6th postpartum day, the fundus is halfway between the umbilicus and the symphysis pubis. By 2 weeks, the uterus should not be palpable abdominally, which means that it's settled into the pelvis. There's a definition called autolysis in your book that's defined as self-destruction of excess hypertrophied tissue, progesterone and estrogen cause this hyperplasia and hypertrophy during pregnancy. So part of the normal involution process is this autolysis, where it breaks down the addition of cells and the growth of the cells. The term subinvolution is the failure of the uterus to return to the non-pregnant state. The most common causes are retained placenta fragments and infections. Next are contractions. Postpartum hemostasis is achieved by uterine contractions. The pituitary gland releases oxytocin, and this is to strengthen and coordinate the contractions, or sometimes they're called afterpains if they are very extreme. Pitocin and breastfeeding combined decrease blood loss. However, afterpains are these uncomfortable cramping and are more common in multips and when the uterus was overdistended. So remember, the uterus is a muscle, so the harder it has to contract to shrink down, the more pain, or those afterpains, that it causes for the mother. So when you are breastfeeding, you release pitocin, oxytocin, and that causes the uterus to clamp down. If you've had more than one baby, it has to work harder to clamp down, or if the uterus was overdistended. So that could have been from an excess amount of fluid. It could be from multiples. And then the last bullet point on this slide talks about the placenta site, and that's the spot in the uterus where the placenta actually comes off, and it kind of leaves an open wound inside the uterus. So how it repairs is an upward growth of the endometrium, which causes sloughing of the necrotic tissue and prevents scar formation. So it's a little bit different than how other sites heal. And the reason that it's this upward growth of the endometrium is to preserve pregnancy in the future. Lochia, you'll talk a lot about lochia. You'll talk a lot about lochia in the clinical setting. It's, a way to know how mom is doing and how mom's recovering. So lochia is defined as the post-birth uterine discharge, and there's 3 different categories. Lochia rubra is dark red. It's made up of blood and the decidual and trophoblastic debris. It's what they experience, pretty immediately after delivery, the bright red, and sometimes has small clots in it. Lochia serosa is pink or brown in color, and it occurs by approximately 3 to 4 days postpartum. It's made up of old blood, serum, and leukocytes. So you have Lochia rubra till 3 to 4 days, and then you have Lochia serosa. Then the third type of lochia is Lochia alba. It's yellow or white, and it shows up at about 10 to 14 days. It's mainly made up of leukocytes, cells, and mucus. Just kind of some more facts about lochia. It's usually less after a mother has a C-section, and this is because the surgeon, basically wipes out all of the debris and the bleeding and the clots outside of the uterus, so it doesn't have to come out vaginally. It increases after ambulation and breastfeeding, and just know that when mom is sitting down or laying down, the blood pools in the vagina, and so when she stands up, she's going to have a small gush of blood or possibly a couple of clots. It's nothing to be concerned about unless it's active bleeding. If you have Lochia rubra, if it's persistent Lochia rubra, it's usually a result of retained placenta. If you have Lochia alba at 3 to 4 weeks postpartum, combined with fever, pain, and abdominal tenderness, it could be a sign of endometritis, so infection. It's always important to know what the odor of lochia is. As gross as that may sound, it's important to know if it has a smell. If it's any kind of offensive odor, it indicates infection. So really the lochia should not smell any different than a normal menstrual flow. Next is the cervix, and it shrinks down, dilates to 10 centimeters for the baby to come out. It shrinks down to 2 to 3 centimeters by 2 to 3 days postpartum. And then it further shrinks down to approximately 1 centimeter by 1 week postpartum. The cervical os is never that circular shape again. It's defined as a split, a fish mouth, or it's like a sideways kind of slit. So you can tell if a female has had a previous vaginal delivery by the way her cervix looks, or not necessarily even a vaginal delivery if she's labored before. Lactation delays production of any kind of vaginal and cervical mucus, and we'll talk about that later, but that can cause painful intercourse for females after delivery. Next is the vagina and the perineum. The size of the vagina never really returns to pre-pregnancy state, but it does regain a lot of the strength and the tone that it had before. Postpartum estrogen deprivation is responsible for vaginal mucosa thinness and the absence of rugae. Vaginal dryness due to decreased estrogen is common, and so you can encourage those new moms to use lubricant during intercourse. It's easiest to view episiotomies and lacerations with the patient on her side, and then you lift up the upper buttock. You can also put them in a lithotomy position, but usually the nurse would just roll her on her side. You want to, same as any kind of incision, you want to watch for any signs of an infection and lack of approximation of the sides, so you want to make sure it's well approximated and healing well. Hemorrhoids are common, but they usually decrease in size by 6 weeks. The pelvic muscular support. Pelvic relaxation that normally occurs after vaginal delivery can cause later gynecological problems that may require surgery. So it's important that all moms, whether they deliver by vaginal delivery or C-section, that they continue to do the Kegel or Kegel exercises, depending on how you say it, to strengthen those muscles. This diagram shows in A, this part right here shows the height of the fundus within the pelvis and abdomen, and shows normal progress for days 1 through 9 postpartum. And you can see that the fundus will be above the umbilicus if you have a full bladder. B shows the approximate location of the fundus 2 hours after birth. So you can see it's just right above the umbilicus. C shows 2 days after birth, the location of the umbilicus. And D shows the location 4 days after birth.